Good evening, everybody. I want to welcome all of you to our webinar tonight entitled All in the Family, Streamlining the Crown and Bridge Workflow. I want to thank the many of you whose names I've seen before. The people at Viva just informed me that I am currently the league leader in all-time webinars with 18. So I know some of you have been attending all of my webinars. I want to thank you for that. It's always fun doing these and putting a little twist and spin on things that we do. And I hope you enjoy what I'm going to present tonight. And feel free to ask questions, and I'll go ahead and I will be able to answer everything really at the end. As usual, my disclosure, I do consult, advise, and lecture on behalf of many dental manufacturers. When I'm not lecturing, I practice full-time in our offices. We have 2 offices, and I practice in New York full-time, as a matter of fact. Right now it's 7 o'clock here in New York, and I walked out of my office at 6:21 this evening, so I really do practice full-time. Anything I'll talk about today in any program that you see me at are procedures, materials, technology, techniques that I use day to day and perform every day in our offices. And tonight I want to graciously thank Kerr for sponsoring this webinar. So let's get right into it and talk about our materials when it comes to Crown and Bridge. Literally just now as I walked out of the office, an hour before I walked out, I prepped up an impression, tooth number 29. And you know, in any given day, I think we have a choice of a plethora of materials from a variety of manufacturers. So we have impression materials that come in a variety of colors from different manufacturers. We have temporary bisacryl type materials that come from a variety of manufacturers. We have temporary cements that come from a variety of manufacturers, and we have permanent cements, of course, that come from a variety of manufacturers, and many of us have basically a library of materials that we have in our office for the things that we do, never thinking for a second that we're making what we're doing a little bit confusing. You know, what temporary cement do you want, doctor? Do you want this one or this one? What impression material do you want? Most dentists have an average of 3.5 cements in their practice, permanent cements in their practice, and usually from different manufacturers. So as a general rule, we make what we do very, very confusing, and it's really not necessary to do that. So just imagine that if we had materials from one company, everything across the board. I'm talking temporization materials, temporary cements, impression materials, permanent cements, and you wouldn't have to figure out what manufacturer would you like. Well, we'll talk tonight about a lot of these materials and how they interplay with what we do, but Kerr has made it easy for us because they have it all, and you don't have to pick and choose and think about and speak to different reps and test different materials. You have the tried, true, trusted name of Kerr, and they make everything that we need to complete a crown from start to finish. So let's talk step by step about Crown and Bridge materials, where we are, where we're going today. So we're going to streamline everything, and the goal for me at the end of this hour is for all of you to feel comfortable that I've added a little pearl into what you do and have made things a little bit easier, quicker in your day-to-day practice. Let's first talk about the preparation. Well, the preparation today or any day, we want that preparation to be as ideal as possible. Is it always possible to do that? No, we have different situations. We have fractures, we have breaks, we have old restorations that we have in there. But if you have an old restoration, like I just had in the crown that I prepared, you have to go ahead and remove the old restoration. We don't want to go ahead and build on something that's been there for 8 years, 10 years, or 15 years. That being said, we want to create an ideal preparation, and that preparation really is based on your material choice today. What is going to be the final material that you will restore your crown with? Because that's going to dictate how much reduction you need, axial reduction, occlusal reduction, and ultimately how much support that restorative material will have at the end. That all being said, I'm a firm believer in smoothing off all the preparations with a fine grit diamond. It's just, your laboratory will appreciate it. For them, fabricating anything is always easier on a smooth preparation. So you want that preparation to look like this. This is my buddy Frankie Shull. Frankie and I just spoke at the Greater New York Dental Meeting. We did a live patient, and he showed this slide. I said, Frankie, I got to get this slide because it just depicts what an ideal preparation should be. Notice you have an occlusal reduction that's anatomically correct. Notice you have a buccal wall that is parallel in that gingival third, but tips in the incisal third. You have a nice parallel lingual wall, and you have a finish line that actually follows the soft tissue as it curves up to the interproximal. You can, in your mind's eye, imagine that when you put a crown on this at the end, that crown is going to seat beautifully and fit well, and your laboratory will easily be able to fabricate a crown to this. And we'll talk laboratories in a little bit and the troubles that they have. Our choices today are many. The more common ones, really the first two, lithium disilicate, which is Emax, and zirconia, are the two most common materials we're using today in dentistry. We've gotten away from PFMs. The majority of us are doing so few PFMs and much more zirconia and Emax. Very different from 5 years ago, where 5 years ago, PFMs were the more popular material, and very little of us were doing zirconia and Emax. Well, today, most of us are doing more of our restorations in Emax and zirconia, with very little being PFM. But there are other materials out there as well. Gladwell has their own material. It's a lithium silicate material called obsidian. Vita enamel blocks are another very aesthetic material that's out there. Lava Ultimate, many of us use that product from 3M and GC's got an interesting product out there now called CeraSmart, which is actually a ceramic that has some composite in it. What's nice about that is if something breaks, you can easily add to it, because we all know the difficulty in adding to Emax or even zirconia. So CeraSmart is a material that from GC that allows you actually to add composite, because there's some composite built into the material. If we look, though, at our ideal preparation guideline, and our ideal preparation guideline, this is Ivoclar's, who make Emax, Ivoclar's guideline. Ideally, we're looking for a 1 millimeter finish line with a 1.5 millimeter axial and occlusal reduction the rest of the way around. Does that mean that that has to be the case every single time? The answer is no, but for ideal strength and ideal aesthetics, you really are looking for at least a 1 millimeter finish line and a 1.5 millimeter axial and occlusal reduction. Now, you can get away with 7 or 8 tenths on the buccal or lingual. You can get away with 3 or 4 tenths in certain situations, but you're now deviating from the recommended guideline of Ivoclar. So if you want to stay within proper guidelines, this is really what your prep guide should be. How can you achieve this predictably? Well, the answer is you can use a depth measuring burr, one of those burrs that have a little round gauge on there that you can bury into the buckle. And you can look at burrs from companies such as Access. And the Access burrs, they'll have a burr that'll give you a depth gauge burr that will allow you to gauge exactly how deep your preparation should be and create an ideal preparation when it's all said and done. But if you do that, your laboratory should be able to give you beautiful restorations, whether you like stain or not, stain restorations that will look absolutely ideal. And this is lithium disilicate. This is Emax. And you should be able to get those kind of results from Emax. When we look at the anterior, it's slightly different in that you can now gauge whether you want a minimal, conventional, or an extensive reduction. Well, I might do a minimal reduction if I'm doing what I call a minimal or no prep or slight prep veneer, where I'm only looking for 7 or 8 tenths at the finish line and on the buckle and 1.2 millimeter axial reduction, but they still want a 2 millimeter occlusal reduction. Now, if you're there at 1.5 millimeters, are you going to be fine? Yes. If you're there on a 6/10 or 7/10 incisal reduction, the answer is you're asking for trouble and you're going to stress your material and potentially fracture. Your conventional prep, again, talks about a 1 millimeter finish line, a 1.2 millimeter axial reduction, 1.5 millimeter as you tip in to that incisal edge, and a 2.5 millimeter reduction on the incisal edge. And your extensive preparation, where you could push limits, you really can go as far as 1.2 millimeters on the finish line and 1.5 and 1.7 on the buccal. When might I do an extensive prep? I might do an extensive prep if I had someone who has tetracycline stained teeth, and I want to make sure that we're going to get really good aesthetics, and I don't want any chance of anything showing through. I'm going to go ahead and do a more extensive preparation. So Ivoclar just released strengths, flexural strength of Emax, and flexural strength of Emax was always thought to be around 350 megapascals. Well, the newest numbers from Ivoclar, this is a brand new slide, shows that Emax with a 1 millimeter prep gives you about 500 megapascals of flexural strength. Now, what does that mean, and why is that really important? Well, we'll see as we get to zirconia, because as we start looking at zirconia preparation guidelines and the different types of zirconia, that number comes into play. So keep 500 megapascals for Emax in your head as we go through the next 4 or 5 slides. Ideal preparation guidelines for zirconia are similar to that of Emax. 1 millimeter near the finish line, 1 to 1.5 reduction mid-buccal, 1.5 to 2 on the incisal edge on the anterior. Posterior, you can get away with a millimeter buccal lingual, but you need a 2 millimeter occlusal reduction really to give you the ideal strength. Now, we know zirconia is strong as can be, but zirconia can still break. We've all seen that. If you've done enough and you don't have enough zirconia supporting that tooth, your zirconia can break. Well, here's why that 500 megapascal I think is important for Emax. Zirconia today comes in different flavors. You know, it's not just monolithic zirconia. It's not just vanilla. We have vanilla, we have French vanilla, and we have super French vanilla. So we have monolithic zirconia, we have aesthetic zirconia, and we have what we call translucent zirconia. Well, the monolithic zirconia, which is the traditional zirconia, Bruxer is an example of monolithic zirconia, has an 1100 megapascal, double the strength of Emax. That being said, it's also less than half of the aesthetics of traditional Emax. So what companies started doing is say, well, we got to figure out a way to make zirconia more aesthetic, and they did that. So there's an aesthetic zirconia that is more translucent, that has a 750 megapascal strength, and there's a real translucent zirconia that has a 550 megapascal strength. So if you heard me speak a month and a half ago, I would have said, keep in mind that Emax has 350 megapascals and translucent zirconia has 550. So we've gotten so much more aesthetic with translucent zirconia, yet we're still much stronger than Emax. The reality is today, Emax is right beneath this. It's 500. So there's not a lot of difference between translucent zirconia and Emax when it comes to strength because of the new numbers that come out. So let's take you right to a case. And we take you to one of my patients, and he comes in and says, I hate my old restorations. I want you to change them. So when I teach a crown and bridge course, the first thing I ask is it an easy case or a difficult case? For me, right away, it looks like a pretty easy case. Why? It doesn't show any soft tissue. If it doesn't show any soft tissue, that means my margins potentially can be equigingival and not extend subgingivally. And if I give him a good look and smile, he's going to be really, really happy. So for me, when I retract, I'm like, wow, it's a good thing he doesn't show his smile, because look what we see. We see uneven gingival contours, and if he showed his soft tissue, this now becomes an impossible case, a very difficult case, one that would need crown lengthening and whatnot in order to get things to be even and aesthetic. So the reality is, I'm thrilled that he's not showing soft tissue, because then it becomes a simple case. So we take off the old crown and bridge, we create some preparations, and we want to create ideal preparations the whole way around. But what's our clunker in this case? You see right here, we have a dark tooth here right in the center of his smile. And that's going to cause us a problem. But I want you to look carefully at the preparations. You see a 360-degree finish line the whole way around. And if you can create finish lines like this, your laboratory will definitely be able to go ahead and create beautiful restorations. So the easy case got a little bit harder because of the dark tooth. Well, my laboratory creates prep reduction guides that I can go ahead and make sure that I have enough reduction. And as you can see here, I'm well reduced here in the anterior, which tells me and my laboratory that, hey, I'm going to get potentially an aesthetic restoration, even though they had no idea this tooth was dark, because I didn't. But we have enough buccal reduction here, enough axial reduction, that we should be good in getting something aesthetic. So that's our reduction guide the laboratory makes for us. Here's what the preps look like from the buccal. I've laser troughed the tissue. That dark tooth is going to be a pain in my noggin. But ultimately, when I make the provisionals and I see this tooth is only slightly dark in the provisionals, I'm feeling pretty darn good that when it gets to the final, we can create a nice result. So the provisionals are made from a wax up that we've done before. We'll talk about that in a second. And it's important that we make that wax up to mimic what our final result should be. Because from there, we'll make a suck down in temporaries, and our final result can look like that. And he's absolutely thrilled. Remember, he's not showing the soft tissue, but we've totally turned his smile around. And obviously, we don't see any gray here in the anterior. Again, where ideal preps have to happen. So Cliff didn't like the gold crown on number 9, but he needed an endo on 10. He hated that, and he wanted me to inset a diamond here on number 10. So if we're going to inset a diamond, I need space to inset the diamond in that porcelain, which means I need enough reduction. So I have to go ahead and create enough reduction here that we can go ahead and be able to accommodate not only for the lithium disilicate, the Emax crowns, but also for the inset of the diamond where the material, the lithium disilicate, is not going to be too thin. So when it's all said and done, if we have proper reduction, once again, it will help us support our materials and create lifelike long-term restorations. Again, following our wax-ups and doing our veneer case, is this case easy or hard? This is a hard case. Why is it hard? Well, he doesn't show the soft tissue, but he's hitting edge to edge, right? If he's hitting edge to edge, our occlusion is going to be difficult. It's going to make for a tough case in doing an aesthetic smile recontour, as I call it. This is what he looks like fully retracted. And you see that he is hitting right on those edges, making it an occlusally tough case. But soft tissue contours are good, and he's not going to show it anyway. So we feel pretty darn good that if I go ahead and create the reduction, and once again focus on the preparations, you see the soft tissue, the finish lines are following the soft tissue. We have minimal but ideal reduction. And you see here we have parallel to the buccal wall and tipped in on the incisal edge following ideal contours. We go ahead and make our temporaries, we polish them, and then we're able to get, once again, veneers when it's all said and done that will be aesthetic, that will give them some length, that will now not hit on the incisal edge. So the key is about creating your reduction and making your provisionals. Well, how do you make a provisional? And I've always been one to make a nice provisional. I think it's very, very different if we're making a single tooth provisional versus multi-unit provisional. If we have a single tooth provisional, I think the key is to have a good imprint of the original tooth or crown. Now, if the tooth is broken, do a quick build-up with composite. You don't even have to bond it. Just put some composite on there, light cure it, and then go ahead and take a good impression or imprint of that. So you can fabricate a temporary crown from that impression. The temporary crown needs to be well-fitting without gingival overextensions. So what are your options? Option 1 is alginate. And I used alginate for years, but alginate can be messy. It requires mixing. Mixing leads to bubbles. Bubbles in your impression potentially can lead to voids in your bisacryl or blebs in your bisacryl. So, and those alginates typically need an immediate pour if you're going to make a model and a suck down, or you got to soak it in something to keep it wet. So we stopped using alginates a good number of years back. So we've been using alginate substitutes for number of simple reasons. First of all, you don't need to mix. It comes out of a gun. There's no bubbles because you get a homogeneous material that's vinyl polysiloxane that comes out of the gun. It's extremely accurate. It's dimensionally stable. So that first Kerr material staying in the family is called alginate. And alginate is a vinyl polysiloxane that eliminates all your aggravations, eliminates your bubbles, eliminates your total use of alginate. It's highly accurate. You can pour it multiple times if you wanted to. It can be poured immediately or it can be stored. And you have no dust or hand mixing. It's dispensed either out of a gun or out of a Ultramix type machine or a Pentamix type machine. They make them in large quantities like that. So it's a huge, huge advantage. So it's convenient, it's simple, it's more effective. There's a negative. There's got to be a negative to everything, right? It's slightly more expensive. Not tremendously, but slightly more expensive. But we give that up for the convenience and the accuracy when it's all said and done. So we go ahead and take an alginate impression of the molar that we want to go ahead and replace. And we take our crown off. You see we have a dark prep. I have to create a prep. Notice when we go from here, I know there's a furcation here, so I'm going to have to barrel in to the furcation. I'm going to barrel right into the furcation here, create the ideal preparation, and then we go ahead, inject our bisacryl temporary material, and Kerr makes one. We'll talk about it in a second. And what you see when you take it out is I've barreled into the furcation. I see I'm going to have a nice representation of what I'm looking for of the original crown. Cementing it back in place, that's our provisional. Now, why does the tissue look a little funky? And we'll talk about this because I lasered it. I took an impression. But that provisional is well fitting. And it's all because of I had an exact representation with alginate. What do I do if I have a multi-unit temporary, if I have veneers? Well, I'll take an alginate for the initial impression. I'll send that impression to the laboratory, and have the laboratory wax the case up, make a reduction guide, make me suck downs for temporaries that will look like the final result. My laboratory will take that alginate impression, and they'll make a wax up. So they'll prep the teeth back. They'll make a wax up, make me a suck down or a putty matrix for my provisional. Kerr's temporization material, temp phase, as I said, the strongest material I've used on the market. It's high strength, low wear, and you can tell because when you go at it with an acrylic burr, you can see how tough it really is. Yet it polishes really well. And the beautiful thing for me is that if I have a bubble, if I want to add somewhere, I can use Herculite Ultra, which is their highly filled flowable, Kerr's highly filled flowable, and I can add to that very, very simply without any kind of issue. So we can create nice temporaries that mimic the final or the initial crown just because we're taking our impression with our alginate. And again, you could see the polishability of the temporary here on number 18. You can see it's highly polished. And once again, the goal is for it to look like your permanent restoration when it's all said and done. Anybody can make an ugly looking temporary. It takes a little bit of effort to make a good looking, well-fitting temporary, but it makes it much easier if you're using something like alginate. So you've gotten your preparation, and now you got to create your impression, which seems easy. I mean, impressions are easy, right? Crown and bridge impressions, for me, and I see this, could be the most abused procedure in dentistry. Why do I say that? Well, tissue control is not so easy. What's the goal of tissue control? The goal is to displace tissue so that the impression material can flow past the margin and capture the necessary data needed to fabricate a well-fitting crown. Alternatives today, some people like to scan. And if you scan, that's great. But today we're going to focus really on impressions. But here are some real numbers. And it's not my numbers. This came from a friend of mine who used to run Glidewell Lab. And Glidewell is the biggest lab in the country, so their numbers are well representative of a cross-section of dentists. 50% of all dental impressions don't show the entire margin needed for fabrication of the restoration. 70% of impressions have incomplete finish lines. 36% of dentists retake impressions 3 or more times in a month, and it's not cheap to take these impressions. Well, why does that happen? What are we dealing with? Well, I decided to go to my laboratory and see, I can't believe that's true. Let me go ahead and just pull some impressions out of the bins and see what I found. These are two different dentists. And I think you can clearly see one of the things that's clearly missing here and here are finish lines. And I pulled some more impressions. Again, hard to see finish lines. And more impressions. Now, how does my laboratory make a crown of something like this? It's almost impossible. And once again, it doesn't make a difference how pretty the color is. Our finish lines are absent. So impressions are not as easy for most as we think, because we have two nemesis. What's the first one? First one's blood. Blood is a big nemesis. There's not an impression material today in dentistry that can get past blood. We need to control bleeding, and there are many ways to do that today. Our second biggest nemesis, you guessed it, saliva. So saliva is a big problem as well. Now, we don't even think about saliva because most impression materials, just it gets part of the impression, but you really want a dry prep. The lucky part, the good part for us is that most impression materials can displace some saliva today, but saliva will contaminate an impression. But let's get real. How do we control these things? Well, option number one is cord. Option number two is soft tissue lasers. Option number three are pastes and gels. And option number four, as you probably saw from some of those impressions, nothing. But nothing's not acceptable. Nothing's not acceptable unless you have a super gingival preparation where there's no bleeding, no saliva, no tissue in the way. Otherwise, nothing is not acceptable. What's the goal of the impression? Let's push away the essential margin, create a gap or some space for an impression material to flow past that margin. How do you do that? Well, you pack a piece of cord, if you pack cord, soak it in a hemostatic, and get it well below the margin. That's going to go ahead and be your plug. It's going to stuff up that gingival crevice and prevent anything from coming up. It's going to be a very thin piece of cord, so it's not going to do a whole hell of a lot of retraction, but it will go ahead and stuff up and prevent any kind of leakage coming from the gingival sulcus. Now, the next thing to ideally do is place a wider piece of cord, which will be your displacing cord. That displacing cord will push the tissue away, and if it sits for a small period of time, it'll create a gap for impression material to flow past. And again, Kerr makes impression cord. Ginger braid and ginger knit, whether you like braided or knitted cord. And if that cord is soaked in a hemostatic, it's going to go ahead and control your bleeding. So what are the advantages? It's tried and true. If it's done properly, it's a big if, it works really well. Disadvantage to cord, it is time consuming. You have to wait for that second cord to go ahead and create your retraction. And potentially, if you push too hard and you keep it there too long, you can get tissue trauma. So you have to, with cord, have to really follow what I call the mother-in-law rule. And thank God my mother-in-law is not listening to this webinar. So the rule of the mother-in-law rule says don't press too hard and don't stay too long. So the reality is you don't want to press too hard on the cord, and you don't want to keep it there any longer than you have to. A couple of minutes is more than adequate. You don't want to leave it there for 5 or 10 minutes because that can go ahead and really cause some trauma. That being said, for me, I've been using diode lasers for many years. Why do I use diode lasers? Well, I use diode lasers because they control bleeding. I see what I got. I have nothing to place and nothing to pull. They're relatively inexpensive today. And their energy is absorbed by pigment and hemoglobin, making them great coagulators. So there's not going to be any bleeding. You can use it alone in conjunction with a hemostatic or something like Expasil if you want to absorb curvicular fluid. But the reality is diodes will go ahead and remove tissue width without removing tissue height. Now, my disclosure is I am the pseudo medical director for AMD Lasers, so I do answer all their questions. It's a non-paid position. I don't get anything for it. And AMD, the #1 selling soft tissue laser in the world, has the Picasso and the Picasso Plus and the Picasso Light Plus. Tabletop 2-pound lasers come with wireless foot pedals, disposable tips, and the primary use for me for lasers is laser gingival troughing. If I can get a clear trough, I'm going to get a clear impression. If I'm going to get a clear impression, my laboratory will make me a well-fitting crown. So diodes work by removing internal epithelium by just angling the tip. So I can go ahead and angle that tip. Because the energy is not absorbed by tooth, it's going to create a trough, and you'll be able to have a gap or a space for impression material. What don't you see in the impression is you don't see any bleeding. You go through the lingual, you don't see any bleeding because this material, this unit, this laser, will coagulate any bleeding or any blood vessel. It's subgingival. What you do see is the opening of a finishing line and the clear on the lingual, where it's clear to see, it's clear to see that finish line. Once you have a clear impression and it's all said and done, these tissue tags can be removed with a little skinny syringe and peroxide, and you're ready to impress. There's no waiting, there's no cord, there's nothing here to do at this point. And if you go ahead and trough your impression, this is our molar that I showed you earlier, you will see a beautiful impression, barrel densification, with margins 360 degrees. What don't you see in this impression? And it wasn't rinsed out. You don't see blood. We'll talk about this, but by the way, this is Kerr's impression material, take one. So we'll talk about that in a couple of minutes, a couple of seconds actually. Take one advance is Kerr's vinyl polysiloxane impression material. It has some qualities in an impression material that I think are critically important. Number one, it has outstanding tear strength. You don't want it to tear. If you have a very thin sulcus, you don't want it to tear. It's hydrophilic, so it'll displace salivary fluids. Not necessarily blood, but salivary fluids, yes. It has very good dimensional stability, and I think the most important aspect for most, because some like vanilla and some like chocolate, is the different viscosities. Some like a heavy body in a tray that's fast set, some like a regular set, some like a light body that flows really, really well, some like a regular body flow. So depending on your flavor, you can get it and take one and still stay within that Kerr family. So once I create that diode laser trough that I showed you earlier, and I take my impression that I just showed you, this is take one. This is the regular body in the flowable and the regular tray fast set. And one of the things I want to discourage all of you is don't get enamored by, well, I use a pink material or an orange material. I don't care if you use brown on brown, green on green, red on blue, orange on yellow. The bottom line is the impression is either going to look good or not look good. You're either going to have what you need or not have what you need when it's all said and done. Here you see it's green on green. And when it's all done, you can clearly see the margins. And if you can see the margins, the lab will be able to totally make your crown. Once again here, margins 360 degrees. If you can't see them, don't send it to the lab because you're not going to get back a crown that fits. And yeah, it's not going to be the material. It's going to be iatrogenic error. It's going to be us. So you take your impression, send it off to your lab. We got to submit your provisional. First thing I always do is I clean off the prep. I like to use chlorhexidine to clean off the preparation. It's antibacterial. I don't want to get the brown scuzz underneath. And there are a number of companies that make a chlorhexidine material that you can use. I also want to use an antibacterial temporary cement because I do not want creepage of bacteria underneath, especially if my patient may not be around for 2 or 3 weeks. So there's a product called Tempon Clear. And guess what? It's a Kerr product. What's neat about this is it has triclosan inside. What's triclosan? It's an antibacterial and antifungal agent that's impregnated into the cement. So that in alone makes it a changer because it's different than all the other ones. It's a translucent cement. So you can use it in the anterior. You're not going to have any show through. It's basically a clear cement. It's got moderate strength. It's a fairly strong cement. I wouldn't say it's the strongest for a very, very short preparation, but anything else, it's moderately strong, and the cleanup is very easy because it comes to a gel state. So you actually can almost see, I have some Tempon Clear right here in this provisional, that's how clear that temporary cement is. The cleanup is simple. It sets very quickly, forms a gel state, and we're able to clean this up very, very rapidly. We get to final cementation. Well, final cementation is a whole 4-hour lecture in and of itself, and I tried to shorten it to a number of slides. First thing I always do is I try my crown in. I want to make sure I have an adequate thickness if I'm going to adjust prior to cementation. So if you know you don't have a lot of occlusal reduction, you really need to cement the crown before you do your final reduction. And obviously you don't want to go through the Emax or the zirconia, but you want to make sure if you're going to be down to 7 or 8/10 or a millimeter on the occlusal instead of 1.5 millimeters or 2, I'd like that to be cemented, and I do not want that to be done outside the mouth. Once I do any adjusting, I want to make sure I polish any of the adjusted areas. I want to clean the internal surfaces. How am I going to clean the internal surfaces? Well, it depends on what type of material you're using. We'll talk about that. And then we're going to go ahead and cement. And we can talk about resin-modified glass ionomer versus resin-based cements. I think it's important because cements are a complicated form today. Well, if we talk about cements in general, our conventional cements, our zinc phosphates, our RMGIs, our glass ionomers fall into that conventional cement category. Our self-adhesive cements are a self-etching type cement that does not need any kind of a bonding agent, so to speak, with it. This is our second tier of cements. And our adhesive cements are ones that require either an etch or a primer bond in order to cement with them. As we go from the top of the pyramid to the bottom, our number of steps decrease. So the adhesive cements have the most steps. The conventional cements typically have the least steps. But our strength goes accordingly. So our adhesive cements are our strongest. Our conventional cements are our weakest. I tried it in the mouth. I'm ready to cement. The first thing I do is I want to clean the internal surface of my crown. I use a product from Ivo Clark called IvoClean. It creates an ideal clean internal surface for cementation. So we put a drop into the crown. We let it react for 20 seconds. We use a brush. We brush it in. It removes any impurities that have built up on the inside. We rinse it off, and we're ready to go. I use my GC forceps to take the crown off if it's in the mouth, and we go ahead and agitate it just like that, rinse it, and now I'm ready to cement. If I'm using a lithium disilicate crown at this point, if I'm using Emax, I'm going to treat the internal surface with silane because that enhances bond strength, and it's ideal for porcelain and for Emax. If I'm using zirconia, I need to use a zirconia primer because that'll significantly enhance the bond strength between the resin cements and the materials such as zirconia. You want to apply these for 5 seconds and air dry. An example would be Monobond Plus, which is 3M's first universal primer. It's actually a primer that works for Emax as well as zirconia. It's the only product like that in the industry that I know of. Otherwise, you need either a separate silane or a separate zirconia primer, and a number of manufacturers make a zirconia primer. If you're an RMGI guy or gal, well, Kerr once again makes Nexus RMGI, which is a resin-modified glass ionomer cement. What are the benefits of a resin-modified glass ionomer? Well, the first thing is you have marginal integrity and enhanced durability. It's fluoride releasing, like glass ionomers. You get a very strong cement that resists mechanical forces and will seal the restoration. It can withstand that oral environment. So you have that high caries patient. You may want to think of a resin-modified glass ionomer cement. What's nice about this cement is it has Kerr's dual adhesive technology. So you get micromechanical retention to the sandblasted metal substrate, and you also get ionic bonding to the metal ions of the metal substrate. So you get a dual action of that bonded cement when it's all said and done. The other nice thing about this is you get very simple cleanup. So you can tack cure the cement, and it forms a gel state. And I'm all about cleanup. So this is Nexus RMGI. It forms that gel state, and you can tease that off typically in one step, you get most of it cleaned up just like that. Very different than a lot of the resin modified glass ionomer cements. It's easy. It comes out of a dual barrel syringe. So you dispense it, seat the restoration, tack cure it, remove, and ready to go. If you're going to use a self-etching resin cement, I think one of the biggest game changers we see out there is Kerr's Maxim Elite Chroma Cement. It's a self-etching, self-adhesive resin cement. You might say, big deal. There's plenty of them like that. But the difference is, this cement changes color, letting you know when it's time to clean up, or the optimal time to clean up. We know the problems with all these self-adhesive resin cements. You clean it too soon or too late. Or you light cure it because you want to cure it, and now it's rock hard. It's hard to clean. Well, what's nice about this is Maxim Elite Chroma uses the same unique adhesive monomers that you've come to love in Optibond XTR. We know Optibond's always been a long-term Kerr product that's had phenomenal results. Manufacturers test their adhesives to Optibond because of how good it is. Well, Maxim Elite Chroma has the same unique adhesive monomer that you see in Kerr's Optibond. If you look at an independent study done at the University of Buffalo, it found that Maxim Elite Chroma was the best in class of these type of cements with the highest bond strength in dentin and enamel among the leading self-adhesive resin cements. So your reduction of debonding is greatly reduced. So what's the point? Well, you don't need an adhesive bonding agent with a cement. It goes into the restoration pink and transitions to white. And as it transitions, at the 45-second mark, you can begin removal. You get a full cure at 4 minutes. If you want to tack cure it, go for it. Tack cure it real quick, just like that resin modified glass ionomer cement that you saw. It'll now change color, and you can easily clean it up and remove the cement. And you still, for better bond strengths, want to simonate for porcelain and Z-prime or zirconia primer for zirconia, even though it does bond to those materials. If you're going to go ahead and polish it, I would say wait until the 4-minute mark before you do that. If you look at the bond strength studies to zirconia and base metal, it forms a best-in-class cement as compared to all the other ones, greater than 22 megapascals of bond strength. So when you load it, it loads pink. Looks weird, right? It's pink. But you can clean this up in 45 seconds, or you can tack cure it and it'll turn white. And then if it turns white, I can go ahead and remove the excess from the interproximal, remove the excess from the buccal and lingual, and then you go ahead and finish it up. Notice on the lingual, we didn't cure it, but we just cleaned off the buccal, and we show you the lingual that it's already begun to change color from pink to kind of that pinkish white. And once it gets to a little bit more than that, slightly more white, we go ahead and we're able to clean it. I like to tie a double knot around the floss. Why? Because as I slide it through the interproximal, I'm going to remove any excess cement with a knot in the floss. And when it's all done, this is a zirconia crown that's bonded into place with Kerr's Maxim Elite Chroma. The full smile retracted view shows you easy cleanup, no damage to the soft tissue, and again, once again, an ideal type situation, staying in the Kerr family of products. If you're going to go ahead and bond in veneers, yes, Kerr makes a product. It makes NX3 Nexus. Light cure cement from multiple units, self-etch or total etch. It has great retention because you're going to use an adhesive with it. It's ideal for veneers. Or if you have a short retentive prep. So my rule of thumb is if the prep is really short, bond it in. Use Optibond XTR, use NX3 and bond it in. But you still can get that easy cleanup in the gel state, which is unique to the family of products. So to summarize cements, and we can talk about cements for hours, within the Kerr family, you have it all. It just depends on what you're cementing. And within the family, you have a variety of options, whether it's a resin-modified glass ionomer cement that forms a gel state that has good bond strengths, whether it's Maxim Elite Chroma, a self-etching resin cement that has good bond strengths with the simple color change for cleanup, or if it's your NX3, which is your adhesive resin cement that you'll use your Optibond with. So I think it's important to understand as our materials change, we have to be aware that prep design, impression, and temporization materials and cements may change really as well. The good news ultimately is Kerr has you covered the whole way around, and there's no need to search materials from various companies. And I think that leads into a huge advantage in that I don't need to stock different products from different manufacturers. I can go right down the line, use my Alginaut for my impression, use my temp phase for my temporary material, use my take one for my impression, and pick any one of my cements when it's all said and done. But my go-to, I will tell you, in my office is my Kerr Maxim Elite Chroma. It's just one that it's simple to work and it's different. And if you look at, without knocking anyone, all the other self-etching resin cements, they all work. But there's nothing that really separates one from the other. If I gave you a blank syringe to use, you probably couldn't tell the difference one to the other. The fact that you have the color change with the Maxim Elite as well as the high bond strength, that becomes a game changer for us in our practice, I think. And it allows you to say, hey, maybe this is something I need to explore and work into what I do day in and day out. So what I try to do tonight, and we're going to finish close to being on time. We have plenty of time for question and answer. I have a lot of questions. We'll go through them. What I try to do is kind of simplify your routine crown and bridge, but educate you that get your rep in your office and just say, hey, I want Kerr products across the board, and you're good to go, and you don't have to deviate with other materials and products. I know I have people here from around the world. You know, I want to thank all of you for joining us tonight. I'm going to tackle all the questions now, and just again, thank you again. I want to wish all of you a happy and healthy New Year, and just spend time with your family and enjoy what we got within all our lives, because family really becomes number one. Let's go to the questions. Jessica, thank you so much for the nice compliment. I appreciate that. I'm going to jump into some of the questions. So one of the questions I had was, how fast is the set time in temp phase? Well, temp phase, I will tell you, for me, is the fast set is the fastest setting material that I've ever seen. I mean, it does say a full set in 3 minutes. I will tell you, temp phase has an initial set in probably 20 seconds. That's how fast it really gets set. We do leave it on the tooth and let it set, and we'll go through a slight exothermic reaction. And that exothermic reaction will not cause any kind of substantial shrinkage. Then we take either a hemostat or a crown remover and remove it from the tooth and begin to carve it when it's all said and done. So thank you for that question. I'm going to go through these and see what else we got going on. How do I typically cement zirconia? Well, there's a number of ways you can do that, and I don't care what you use, unless you're using a product like a Ceramir, which doesn't require a zirconia primer. You need to use a zirconia primer. Not that things won't bond or stick to zirconia. The zirconia primers make the cements stick better. So you want to go ahead and use the zirconia primers whenever you can, only because it'll create a better adhesion when it's all said and done. Peter, thank you so much. Have a wonderful holiday as well. I appreciate the nice comment. Can I use regular Keytac for Bruxer? I would suggest not using regular Keytac for Bruxer. Typically, glass ionomers are not, they just don't bond very well to zirconia. I mean, the Nexus one bonds okay. Excuse me, the RMGI, Next RMGI bonds okay, but typically glass ionomers not bond very well. If I was choosing cement to zirconia, I would use Maxim Elite Chroma, or I would bond it in with Optibond and resin cement NX3, and use a zirconia primer on the zirconia for maximum retention. You are risking less adhesion if you use something like Keytech to cement in a bruxer. Very good question, though. I appreciate the question, Lance. It's a good question. It's a question I get asked very often from dentists because cementation today might be the most complicated area that we venture into or go into in dentistry. If you have any questions, I'm going through. Question about diodes. So one thing, while I still have you here, I think I'd be remiss for not saying. Up until today is Thursday, I think up until Monday, if you tell AMD lasers, you heard Ron Kaminer speak, and guys and gals, I get 0 out of this. But if you tell AMD you heard me speak, they will give you half off on any diode till Monday. So till Monday, 50%, you can get into a diode for $2,300 or $2,400. So just say you heard the webinar, and they will do that for you. If you have an issue, speak to Ben and tell him that I said it. I'll get in trouble. But it actually is true. So going through my questions. If there are no other questions, I think we're pretty well done with our webinar. I want to thank all of you for joining me once again tonight. It's truly an honor to have so many repeat people and followers as we go do these webinars. And hopefully next year we'll do half a dozen more. Alita, thank you so much for the nice comments. I appreciate that. Thank you, all of you. Have a happy new year. And really thanks again for attending tonight. Have a great night. Thanks, Lance.